Hello and welcome. My name is John Gross. I'm the bone and soft tissue pathologist at the Johns Hopkins University. Here we have case number 13, which is from a teenager complaining of knee pain. Radiographs were obtained, and here we have a intramedullary mixed sclerotic and lytic mass, which is somewhat eccentric and deforms the overlying cortex. Sagittal views were also reviewed, showing a both lytic and sclerotic mass that deforms the cortex and pushes on it posteriorly, distorting it. And a similar feature was identified with advanced imaging. And you can see the intensity of the mass matches somewhat to the surrounding marrow as well as the cortex. So the differential diagnosis radiographically was concerning for well-differentiated intramedullary low-grade central osteosarcoma, given that its large appearance but somewhat indolent growth, and the specimen was subsequently resected. And here we have a low power view showing this fibroosseous tumor, and it appears to have a indolent growth pattern, kind of pushing on the surrounding cortex. The cells appear very pink at low power with numerous foci of well-formed but kind of odd-shaped bone, somewhat resembling fibrous dysplasia. However, the cells appeared to be a little bit too much, having a little bit too much cytologic atypia for fibrous dysplasia. And as you can see here, the bone lacks osteoblastic rimming. And again, other areas had a little bit too much cytologic atypia, although it's bland, but a little bit too much cytologic atypia for fibrous dysplasia. And MDM2 showed gene amplification. So this is a low-grade central, which is also known as well-differentiated intramedullary osteosarcoma, which is a rare low-grade, grade 1 osteosarcoma variant. So I'd like to discuss with you today some of the osteosarcoma variants. We'll start with conventional osteoblastic osteosarcoma. On the left, we have these malignant cells, which are anaplastic with brisk mitotic activity, and that produce mineralized osteoid matrix, which is this pink and purple material here seen on the left. And on the right, at higher power, these anaplastic cells produce this wispy lace-like osteoid matrix, which again is the definition of a osteosarcoma, a malignant cell that directly produces mineralized osteoid. Here's a collage of different osteosarcoma subtypes. At the top left is fibroblastic osteosarcoma with a low-grade, bland, variably pleomorphic spindle cell sarcoma with scattered spicules and foci of well-formed bone shown here. The top right is an example of telangiectatic osteosarcoma with these blood-filled cystic spaces. However, the tumor is quite cellular, mitotic activity is brisk, even though there's real scant and rare matrix mineralization osteoid formation. The differential diagnosis sometimes with telangiectatic osteosarcoma is aneurysmal bone cyst, often requiring radiographic correlation. However, this is a high-grade anaplastic sarcoma. The chondroblastic subtype of osteosarcoma is seen on the left with this focus of cartilage surrounded by fibroblastic malignant spindle cells. And the bottom right is an example of giant cell rich osteosarcoma with these malignant cells directly producing mineralized osteoid, and then the abundant large osteoclast-like giant cells. Here's a few photomicrographs of the small cell osteosarcoma variant, which is a very rare variant of osteosarcoma. Here, this primitive, pretty small cells on the left can be seen in a filigree osteoid production pattern with this purple and pink matrix, which can be seen easier on the right, that these malignant cells, which are relatively small, mild nuclear atypia, mild nuclear pleomorphism, however, are directly producing this mineralized matrix. And then another very, very rare variant is chondroblastoma-like osteosarcoma. Seen here on the far left, you can see that there's this purple mineralization and an otherwise very pink tumor. And on the right, this is a higher power view showing these epithelioid cells that are variably chondroblastoma-like, some of which even have kidney bean, reniform shaped nuclei, some of which even have nuclear grooves. However, there is matrix mineralization with this purple stuff to the pink matrix quality. And you can see here on the left, or above my name, is mitotic activity, which is variably identified. And of course, this is a osteosarcoma, which has a much worse prognosis than the benign chondroblastoma. Osteosarcoma is the most common non-hematopoietic primary bone tumor with a bimodal distribution in patients younger than 20 and greater than 60 years of age. Osteosarcoma often occurs in the metaphysis of long bones around the knee, for instance, but can affect any bone. Radiographically, osteosarcomas are often ill-defined. They may have a mixed lytic and blastic appearance, similar to our patient in this case. A Codman's triangle may be seen, and that's when the periosteum is elevated by the advancing tumor. Osteosarcomas in general are rapidly growing, which is in contrast to conventional chondrosarcoma, which is more indolent and slow growing. Osteosarcoma is defined by the production of malignant osteoid, that is a malignant tumor that you know is malignant, that is producing osteoid. And sometimes the radiographs are needed to correlate with that. Osteosarcomas often produce the osteoid in a lace-like pattern. It will lack osteoblastic rimming. Osteosarcomas are often invasive and have permeative growth patterns. Majority of osteosarcomas require preoperative chemotherapy. There's a couple variants, this one included, which does not generally have preoperative chemotherapy. Our patient with the low-grade central well-differentiated intramedullary was resected up front, no chemotherapy. The lung is the most common site of metastatic disease. The prognosis of osteosarcoma is variable. With conventional osteosarcomas, 50 to 80% survival. However, the low-grade osteosarcoma variants will have a greater than 90% overall survival. So the low-grade central osteosarcoma is a low-grade malignant bone-forming neoplasm originating centrally. So it originates intramedullary. Typically fibroblastic with only mild cytologic atypia. There's well-formed neoplastic bone trabeculae, which lack osteoblastic rimming. They may have invasive permeative growth of host bone, resembles parosteal osteosarcoma histologically, fibrous dysplasia, as well as desmoplastic fibroma, some of those in the differential diagnosis. Mitotic rate of low-grade central osteosarcoma is quite low. There may be cartilage formation or chondra osseous. Osteoid may be maybe inapparent and quite rare. This is a tumor that has MDM2 amplification. Low-grade central osteosarcoma may dedifferentiate at presentation or in a recurrence, so something to be on the lookout for. And when there is dedifferentiation, that's when chemotherapy can be used. And finally, here's a couple other examples of photomicrographs of low-grade central well-differentiated intramedullary. Again, we have a very bland spindle cell tumor that is producing this wispy lace-like mineralized osteoid on the left at high power. And then on the right, again, we can see this fibroblastic spindle cell sarcoma that has these large reams of atypical osteoid production. And of course, this is a tumor, as I just mentioned, that has MDM2 amplification. Thanks for listening.